Ladies and gentlemen, I would like to thank you very much for inviting me here. Unfortunately, I do not speak Russian, so I have to give this talk in English, and I hope this is going to be translated in a way that you understand what I am talking about. I want to talk about imaging options first in liver disease, then the purpose. Why do we image? I will talk about secondary malignancies first and then about primary malignancies and give you a little bit of an outlook on PET-MR, which is the newest modality which we dispose of. You all know that ultrasound is frequently and widely used. It's widely available, it's low cost, it's useful for biopsy guidance, it's used by imaging specialists, surgeons and hepatologists alike. But it is important that people have experience doing that, and we as imagers sometimes say a non-trained ultrasonographer we like very much because he generates about 1 CT per 5 ultrasounds. X-ray computed tomography is the most widely used imaging in tumor management. It is relatively widely available, and the cost has actually become moderate. It is useful for biopsy guidance. It's used by imaging specialists only. It's suitable for whole body surveys, particularly in tumor staging. It is used. And it is a key component of PET-CT, obviously, and there it is used as a whole body survey. Sensitivity and specificity to characterize lesions is moderate. MR imaging is certainly the best method to characterize liver lesions. It is widely available but relatively costly. It is used by imaging specialists only, and it is partly suitable for whole body surveys, but it takes a relatively long time to get the whole body survey. It's obviously the key component in a PET-MR examination, but I think PET-MR at this point is probably a technology looking for an application, but we can discuss this at the end. It has the highest sensitivity and specificity for liver lesions. Now, PET imaging is certainly the best method for M-staging in malignancies in general and for GI malignancies in particular. The limited availability is a problem because you need to have the logistics of getting radio tracers, and that is not so easy. We have a lot of experience. We have done this for 20 years, and we have a radio tracer facility where we actually supply 2/3 of all tracers for PET in Switzerland. So it can be done, but it is logistically a substantial operation. It is used by imaging specialists only, and in my opinion, the best thing is if you are doubly trained in nuclear medicine and radiology. It is excellent for whole body surveys, and it is nowadays only used as PET-CT. I mean, you cannot buy a PET scanner anymore because the technology has been so useful. There is a high sensitivity for liver metastases, but there is a certain size limitation. Lesions which are smaller than 5 to 8 millimeters may go undetected. Post-therapeutic FDG uptake is highly predictive of outcome. So this is very interesting. FDG is really a very good predictor of malignancy. I frequently say if you have FDG uptake in a lesion, that's bad news. If you have FDG uptake in the lesion after therapy, that's really very bad news. Now, what are the purposes of imaging? On the first hand, it's tumor characterization, and the second is staging. Now, if you want to do tumor characterization prior to biopsy, that certainly is the domain of ultrasound and particularly of MRI, which is very good at lesion characterization. But when you come to staging, and that's the issue in oncology, then this is the domain of CT and PET-CT. If I ask my liver surgeon or all my surgeons, why do you want to have a PET scan, they always say M-staging. PET is not so good in T-staging. It is sometimes useful in N-staging, as in bronchial carcinoma, but in most tumors, the key information provided by PET-CT is the M stage. And that's obviously very critical, for instance, for patients with colorectal cancer, because if you find a liver metastasis and you find no other metastases, you will then be able to do surgery on the patient. Now, therapy control and disease monitoring is becoming more and more important as we are handling tumors better and better, and tumors get more and more chronic. So we do a lot of disease monitoring. It is clear that FDG PET is better than dynamic contrast enhanced MRI because it measures something different, something which people don't understand sometimes. You know, perfusion is a decent parameter to look at tumor response, but there is tumors which are poorly perfused, which are still living and active, and FDG doesn't measure perfusion. FDG, the radioactively labeled sugar we use in PET, measures essentially FDG, or sugar metabolism. Prognosis and outcome, I have mentioned, is the domain of PET. So let's first start with the secondary malignancies, because they are the more frequent malignancies where we discover liver metastases. And I have told you the issue of PET versus PET-CT is a no issue. It has been proven time and again that PET is not so good as PET-CT. Now, we have learned that you really need a dedicated reading of the CT scan in a PET-CT. So it is not good enough to say, I'm taking a nuclear physician and he uses the CT for anatomic correlation. It is really critical that you read the CT carefully and that you do this with the diligence and the know-how of a radiologist. This is a patient with a hepatic tumor, and you can see that this patient had a lesion here. You can see that, and then the patient underwent surgery and the lesion is gone. Now, that is maybe, you know, not a very typical indication, but what would happen in this case is probably the surgeon wanted to know eventually after a few months, does the patient have a recurrence? So we're talking about initial staging. So when you see a patient who has colorectal cancer, what is the initial workup? Here we have a transverse colon colorectal cancer, and you can see that we have all these cystic lesions in the liver. And the question obviously is, are these cystic lesions metastatic or are they just liver cysts? Here is the primary. And here you see primary. And then when you look at the liver here already in this maximum intensity projection image, you can see that we certainly have a problem. This patient is full of liver metastases. So these are cystically degenerating metastases. And this is hard to identify on CT alone. Now here we have, on the other hand, a patient with advanced colorectal cancer. You can see the primary sitting here in the abdomen here. And you see that the patient has a big liver metastasis, but unfortunately the patient also has some lymph node metastasis, which makes him, according to standard rules, inoperable. So this is a critical information which the surgeon needs to have. Now when you look at the NCCN guidelines, these are the American cancer of the National Institutes of Cancer. They give these guidelines, and in these guidelines you can see that that PET is actually quite indicated when you have recurrence. So the issue with initial diagnosis of colorectal cancer and doing PET imaging is not fully decided. In our hospital, what we would do is, if the patient has relatively advanced cancer, he will get a PET-CT. If the patient has a lower stage tumor, he will not get a PET-CT at initial presentation. However, as you can see here in recurrence, the PET-CT is clearly indicated, and the recurrence is very frequently identified by having a rising level of CEA. Now, our surgeon, chief of surgery, Pierre Alain Clavien, is a very gifted and wild surgeon, so as to speak. The liver is a very interesting organ because what you can do is you can cut part away and then regrow another part. And so what he's doing is even operations where he actually takes away a substantial part of the liver, regrows it, and then does surgery again on the liver. For this, he needs a very good delineation of the liver segments for operation. And so for that, you need PET-CT with contrast media, or you also need an MR scan. For recurrent disease, depending on what the outlook is, we have many different treatment modalities now. We have not only surgery, but radiofrequency ablation, cryoablation. We have yttrium beads to treat these liver metastases. So in a surgical oncological conference, it has to be decided what is the best approach to treat the patient. Now, we have come to the conclusion that if you when you do PET-CT, you have the option to do a low-dose CT, which you mainly need for anatomic correlation. And there are certain settings, like in lymphoma, where this is probably good enough. However, our data and data of others suggest that when you do PET-CT in colorectal cancer recurrence, you need a contrast-enhanced CT. So what we would do is when the patient comes to us for a PET-CT, we would immediately do a contrast-enhanced CT as part of the examination. Here you have a patient with liver metastases in a recurrent setting. Now, PET-CT has been evaluated against MR, and it seems that these two modalities are fairly comparable, with the great advantage of PET-CT that it gives you the issue of distant metastases, or the information on distant metastases. In fact, it is, the argument would go, MR has a better contrast, soft tissue contrast than CT, but it is very, very rare that you will miss a lesion on CT when you do contrast enhancement. Most lesions really are identified. So here we have a patient with a local hepatic recurrence. You can see the lesion. You can see the site of surgery here. And obviously, this patient has a recurrent tumor, as indicated by focal and very strong uptake of FDG. Here is the surgical finding. Now, as I pointed out, you should use contrast-enhanced CT in PET-CT, and here are the data. So this is a study where we looked at 50 patients, and we were asking the question, how many of these patients do you find additional information when you do a contrast-enhanced CT versus just a non-enhanced CT? And you can see that in 30 patients out of 50, we had additional information. And so, in fact, this information resulted in a change of therapy management in 18 patients. So this is a third of all patients underwent a change of management. And this is actually sort of a general figure. If when you do PET-CT and you evaluate PET-CT, it is very difficult to have information on outcome. How does PET-CT change the outcome of the patient? It's very difficult to find that out. What we can find out relatively easily is, has the PET-CT information changed the management of the patient? And in general, if you look at the literature, PET-CT in most oncology cases will change the management, the tumor management. In some major prognostic quality, or FDG PET. There's other tracers, but FDG PET. And I show you some data here from an Australian group. What you see here is a patient with a rectal cancer, and this patient gets treated, and after treatment, the patient has not improved. In fact, you can see that the patient has some liver metastasis which grew under therapy. And in fact, in all tumors, when you draw these Kaplan-Meier plots and you stratify in patients who after therapy showed a decrease or complete lack of FDG versus those who maintained FDG uptake in the lesion, it has a very, very heavy prognostic implication. So these patients responded by FDG. So FDG was negative in these patients. You can see those who have persistent FDG uptake, they die very quickly. So FDG is a very good marker of malignancy and is an outcome stratifier. In GIST tumors, PET is also very useful because in GIST tumors, if they are treated, you immediately see a response. You can treat them with tyrosine kinase inhibitors. You can see that in this patient, it is still full of liver lesions, but the lesions are no longer FDG active. So this is a good result. This is actually this patient, and again, it's a little boring what I'm telling you, but this is another of these Kaplan-Meier curves stratifying that if you have persistent FDG uptake, the patient will not do well. We have other tracers, like in neuroendocrine tumors, we have these gallium dotapeptides, very excellent tracers which are very useful in neuroendocrine tumors, which can also, as you know, metastasize to the liver. Let us now turn to primary malignancies, and here is a hepatocellular carcinoma. Hepatocellular carcinoma, when they are slowly growing, will not take up a lot of FDG. And again, that's the other side of the coin. When I tell you FDG is a marker of malignancy, then obviously less aggressive tumors will not take up as much FDG. For instance, in prostate cancer, FDG is not a very good tracer because prostate cancer usually is a slowly growing tumor. So here we have a patient with HCC, and in these settings, obviously it is a very good tool to evaluate therapy monitoring. So this patient had some chemo embolization. This is the primary tumor prior to chemoembolization, and you can see this is the tumor after chemoembolization. So while this may still be some inflammatory response to the therapy, this probably is a site which has not been treated successfully. Based on these data, one may decide whether we want to focally ablate this lesion again. So again, this is quite a valuable thing. Obviously, hepatocellular carcinomas do not produce, not very frequently, they produce metastases, but if they produce metastases, you will see them well on PET-CT. Now let me give you some information on PET-MR. We have been lucky enough to play with this technology for the last 3 years. The conclusion is this is a very challenging technology because PET and MR don't like each other, so you have a lot of technical issues, and I don't want to belabor those, but you just please understand PET-CT is like brother and sister, and I don't know, PET and MR is like the devil and God or something like that. It just doesn't, you have to do a lot of technological changes to get this together. I told you at the beginning it is a technology in search of applications probably because PET-CT is doing so well. And so when you start to do comparative studies, where could PET-MR make a difference? This is not so obvious at this time point. I mean, there haven't been too many systems out and there is not too many studies out. And people also really don't know how to use MR properly in a PET-MR environment. And so I think one is in the process right now to sort of reinvent MR. How do I have to run MR that it fits well together with PET? Now, why is PET-MR potentially interesting in liver tumor assessment? It's obviously the case because MR is so good in liver tumor imaging. And I think what may happen is that eventually, I told you for small lesions, PET may miss some metastases in the liver. And so what we are thinking about is developing these, what I call rule-out metastases protocols, which do not require a lot of MR imaging time, but you can then do a whole body survey, tumor staging with PET-MR, and then at the end you go back and you do a very short, maybe 10-minute run just over the liver with contrast media. And at the end you can say, this patient certainly has no liver metastasis, period. And if you start to find interesting things in the liver which are not tumorous, but other things which you need to identify, you can still take the patient out of the very expensive PET-MR scanner and put the patient into an MR to do the additional pulse sequences which you need to understand what the patient has. So we need to develop a clinical workflow. So PET-MR is interesting because it is the first and only imaging modality where you can measure two images at the same time. So it's simultaneous. So what PET-MR does is it steps through the patient and acquires PET and MR. And for MR, this is a very fast sequence, and so you have to be clever to run the right MR pulse sequences. And here we have some data, and there maybe we don't need any contrast media in MR. We just don't know very well what it is, but I just wanted to tell you this technology is on the horizon and is certainly a very interesting technology for academic applications. So in conclusion then, I think imaging is critical to define a personal therapy plan for each patient, and in the age of personalized medicine, this is obviously key. Lesion characterization is best done by MR. Staging and therapy monitoring is the domain of PET-CT. FDG PET has a major prognostic value, and PET-MR will come, and we think it may have an important role in liver tumors, but it is much too early to tell. Thank you very much for your attention.